Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. We have a very special show here tonight. A good friend, Dr. Gilchrist, who's the Chief of Pediatric Surgery at Richmond University Medical Center. He's going to be talking about pediatric surgery. That's a big topic. So we're thrilled to have you here. And especially now we're towards the end of the pandemic and our ORs, operating rooms, are getting more and more busy. And sad to say, kids are also getting sick and having surgical procedures. And as you just mentioned to me, you're in Brooklyn and Staten Island, your practice, and there's a lot busier than it had been over the last year. So it's really wonderful to see all the things that you're doing right now. So we're going to talk about pediatric surgery. And really, maybe from the very beginning, I know you're a physician, you're an MD. Tell us what training it takes to be a surgeon, and what makes it special to be a pediatric surgeon.
Well, what makes it special is that you're taking care of the kids. So the way to think about it is there's only 475 pediatric surgeons in the United States. That's it. It's a incredibly difficult specialty to get into. You have to do general surgery first, which is 5 years. Most of us have done 2 years of research within there, so that's 7 years, and then 2 years of pediatric surgical training at a children's hospital. So it makes you a super specialist, because we end up doing everything except the brain and the heart. Every system is something that we operate on and take care of.
So what are the more common surgical procedures that you do?
Well, the number one abdominal emergency in a child is appendicitis. That's still number one. But I do a lot of hernias. I do a lot of orchiopexy when you have an undescended testicle. I do a lot of urology, and we do a lot of tumor surgery. The other thing that we do a lot of, especially at Richmond University Medical Center, is we do a lot of neonatal surgery, where the children are born with anomalies that have to be fixed right away.
So tell us a little bit about children. As an adult neurologist, most of adult doctors, our perception is that children are just little adults. Yeah. And we see that from all the paintings in the 17th and 18th century. They sort of look like adults, but just smaller.
Yeah, nothing could be further. Nothing could be further from the truth.
So tell us what makes children unique.
Remember now, a kid, especially a baby, is made out of water. They're 90% water. Their tissues are as fine as can be, and very, very fragile. And also the fluid requirements that a child has are entirely different from adults. So when you take care of a child from a technical point of view, it takes a gentility and a respect for tissue that you don't have to necessarily have for the adults. Post-operatively, the management is entirely different because of the equilibrium and the fluid fluxes that go on.
Tell me about the team that you have. You mentioned the post-operative care. What about the anesthesiologists and people like that?
At Richmond University Medical Center, Peter Carpenito, who everybody knows on Staten Island, is the chairman of anesthesia. And he has gotten 3 people in pediatric anesthesia there that are utterly superb. I've been in children's hospitals most of my life, and I don't think I've ever seen better anesthesia than is given for the kids at Rumsey.
Mm-hmm. Or like when sometimes you don't know if you have an appendicitis and you bring your child to the hospital. Is there any way to know whether a hospital is a cutting-edge pediatric surgical center? Is every hospital on that level?
No, not at all. I think your point's taken. You have to have a team of people who are completely focused on pediatric surgery. And at Richmond University Medical Center, this is especially true. They have pediatric ER doctors, they have pediatric radiologists, they have pediatric anesthesia. The surgery part of it is, of course, key, but the other parts are just as important as what I do.
Tell us where else do you practice here in Brooklyn also?
Well, I'm the chief at Brooklyn Hospital, which is in my neighborhood, so I can walk to work. But I'm here every day at Staten Island because my love has been taking care of the kids on Staten Island.
That's wonderful. So not every hospital is a place that we should feel comfortable with.
Not at all.
There's really no way to know when you go to the hospital, is there?
I think if you have a pediatric surgeon at your hospital, you can pretty much assume that everybody around him is going to be a specialist in pediatrics, because a pediatric surgeon is just not going to work in a hospital that can't perform up to the level that he needs.
What's the relationship between a pediatric surgeon? We think about pediatricians being so different than adult physicians in the relationship with the kids' parents. So tell us how you interact with family and in other way that's different than you think about during your general training.
I try to treat every kid like it's my own kid. And I want to make sure that all the I's are dotted and the T's are crossed. And the pediatricians, as a group, people who focus on pediatrics are often very kind people. It's their nature, and they're gentle, but they're also very compulsive about care. So I think when you deal with pediatricians, you're dealing with people who also treat the kids like they're their own.
That's interesting. As an adult neurologist, in our training, we do pediatric neurology. And it's a whole different group of people with a lot of genetic issues and families and also different kind of illnesses than we see in adults. But just the idea of, other than in my medical school days, of spending a few months, I trained at Columbia in Presbyterian Hospital in Manhattan. They had a babies hospital. And the idea of seeing children with neurological deficits really is very, very different. It's very moving, and it's very, very difficult in a lot of ways. So you really have to be a very special person, at least in the field of pediatric neurology. At least with pediatric surgery, a lot of times you feel like you are able to complete a task. You're able to get someone whole again, which is really a marvelous thing.
There's a sadness to it too, though. You got to realize that the greatest sorrow in the world is the loss of a child to a parent. And one of the other things that's horrible in life is to have a sick kid. And these things take a special sensitivity and soulfulness that you have to have in order to get through some of those situations. Certainly the gratification of taking care of a kid and making him whole again is magnificent. But I warn the young guys coming up, trying to train them, that there's going to be days when your heart's going to break because sometimes it's a very tough proposition.
Tell us about some of the newer techniques in pediatric surgery. I mean, we know about in adults, and again, there's more from my education, laparoscopic procedures, robotic procedures.
Well, it's interesting. The robot is, I do all laparoscopy. I do almost everything with the laparoscope, so it's minimally invasive surgery. I do it also for pilonidal disease, where I don't cut anything out anymore. We've all sort of gotten into the mindset of doing things minimally, so there's no pain. But it's very interesting that just last week, a big breakthrough came through in Germany, where they have a platform now for the robots for the kids. Prior to this last development is the robot modality are too big for the kids, but they've now miniaturized it so that the ports where you go through the umbilicus, etc., is now going to be okay for robots. So robots are here to stay. The future's here, even for the kids. So I think over the next 3 or 4 years, you're going to see tremendous advancements in just robotic surgery for the children.
So tell us about, give maybe even a little bit more detail. What is robotic? What is laparoscopic? We always think about surgery as someone opening you up and taking a look and putting it all together.
Those days are over.
Tell everybody out front, because I want to take some of the fears out of surgery.
Yeah, the thing about laparoscopy is, here's the way to think about it. You can stick something the size of just a needle through your umbilicus, obviously when
That's
you're
your belly
asleep.
button.
Your belly button. You can stick a needle, and actually the optics are such that you can see everything, just like you could when it was open. The optics, the technology has become so phenomenally accurate that you don't need to make an incision. You don't need to cut anybody. You can see everything, and the equipment that we use in laparoscopy gives you some facility, but the robot is even a greater facility because you have 360 degrees ability to use the instruments, which you don't have with a laparoscope. So everything has been predicated now on minimal invasion and the ability to facilitate inside the abdomen with these new instruments.
And people in the post-operative care is easier, and people go home sooner.
I do an appendix, and you're home I take your appendix off the laparoscope, you're home within 6 or 7 hours.
Wow.
I mean, in the old days, you'd be in a hospital for days. You're home. I haven't had an appendix stay in a hospital more than 24 hours in years.
That's interesting. That's amazing.
Yeah.
So we want to always take the fear out of some of these procedures, because so many patients, I mean, even we're late in the pandemic now with COVID, some people didn't want to get vaccines for a number of reasons. People are afraid to go to their doctor for surgery, whether it's adults or having their child. But it sounds like you've taken a lot of the risk and some of the fear out of it. Of course, there are complications always that have to be discussed in reality there. But I think we've come a long way in the last 10 years.
It's been phenomenal. It's really been phenomenal. And anytime you go to a meeting or a convention, There's new technologies, there's new equipment. Every day somebody's out there figuring a new way out to make it easier to operate on a patient and not hurt them.
So let's talk about some of your new things. There's a lot of research going on, and you came to me, you said, that when we were talking at the doctor's lounge for a moment, and you said, you know what, I have this very new technology for kids that's really not around for any place else in the country, or very few spots in the country. And we're doing a study here, and again, not to promote people to come to the study specifically, but just the idea, and when you mentioned it to me, I said, wow. And I don't say wow that often. You know, I'm thankful with some of the technology and meeting people like you, of course, on a daily basis, and seeing families and taking care of patients. There's a lot of wow. But to say it out, I said, wow, that's a brilliant idea. So tell us a little bit about what the new program you're doing.
I don't want to take any credit for these ideas, but I want to talk about cool sculpting for a second for kids. If you, 20 years ago, I started a program in bariatric surgery for children. Remember now, the society is getting bigger all the time. Obesity has become a huge problem. If you're obese at 8, you'll be obese at 18, you'll be obese at 28, and all the attendant problems that you have from carrying too much weight. Now, when I did that program, this was in Boston, when I first started that program, we couldn't get anybody insured through the insurance companies to have the surgery. So you have to show 6 months of exercise or diet. And the boys would not exercise because they didn't want to take off their shirts because they had breasts. And therefore, we started a program where we did a mastectomy for cosmesis for the kids.
So cosmetically?
Cosmetically, not for a cancer, but to have these kids then go to the gym, take off their shirts, go swimming, et cetera, et cetera. Of all the surgery I've done, and I've done every conceivable operation you can do on a kid, I don't think I've ever had more gratifying kids than these boys whose breasts I took off. Because then they started to exercise, they became less self-conscious, and they enjoyed life again. It was a tremendous insight for me. Fast forward 20 years, now cool sculpting is out there.
Tell us what cool sculpting is.
So cool sculpting is a very interesting concept. If you have extra weight, if you're putting on weight, and you go on a diet and you lose the weight, all that happens is the adipocyte, the cells, the fat cells, get smaller or larger, depending on your diet. But they're always there. Once they're laid down, they're there. Cool sculpting, which came about at Harvard, where I trained, is a concept where they take suction cups and they place it on the fat, and they then take it down to minus 11 degrees centigrade. They freeze the tissues, and the tissues then dissolve. And once they're frozen, they then are picked up by the lymphatics and they're gone. They are essentially gone.
Sort of the garbage picker-uppers.
That's right. They're the garbage trucks of your system. And the lymphatics pick up the cells, and the adipocytes are gone. So now, if you have a deposition of fat on your sides, at your breast if you're a boy, the women get it along their bra straps, you can take these suction cups. It's painless. You don't need anesthesia. There's no cutting. And you attach them, and you shrink them down. It's incredible, the results. So it's only been approved for adults. It's never been approved for kids under 18. The FDA has not approved it for people under, so it's an orphan. In order for me to use it and to utilize it, it has to be written up on a consent as an orphan drug or orphan technique. And it's, if you're 20 or 30 pounds overweight and you cannot get rid of that fat, the cool sculpting gets rid of it. It may take 2 or 3 shots at doing it, but it works like, it's incredible how it works. So I've put together a program where I want to do the children, the teenagers especially, are very self-conscious. They are hypersensitive to these things, and they want to have these fat depositions removed, and we can do it without pain.
Tell us about the medical issues with regard to this. So we know that bariatric surgery is, and again, not to use a too broad a stroke, can almost cure diabetes in a lot of patients. So in the younger people, and that's a whole different approach because you're cutting out or affecting part of the stomach. The stomach has certain hormones and enzymes that are being produced. So there's a reason this happens. When you take out the fat cells, do you get some of the metabolic benefits also?
Sure, But I want to just step back for a second and talk about bariatric surgery for a minute so that the public really understands this. 100 years from now, 50 years from now, people are going to look back and shake their heads and go, I can't believe they did these operations.
Really?
Yeah, because it's a totally non-scientific operation. You take out a section of the stomach where you think all the ghrelin receptors are, but you don't really know where they all are. And these people, if you look at the recrudescence of weight these people put on after bariatric surgery, you have to say to yourself, sure, it does knock down diabetes, sure, it does knock down weight, but a lot of these people get the weight back. So it's much more complicated than just cutting out a part of your stomach and thinking you're going to get better. For me, ultimately, they'll come up with a monoclonal antibody or some receptor site that is in your brain that'll stop your satiety and stop your desire to eat. I think that's the future. I don't think it's really a surgical disease. But having said that, it's what we have now. When you were coming up, they were doing radical mastectomies, and the guys thought it was the right thing to do for cancer of breast. That's completely changed. Melanoma surgery, we used to take out huge chunks of the body. Nobody does that anymore. The better we understand these things and can tailor these things, the better results we get and the less invasion we do to people's bodies. Now you take cool sculpting. So you have somebody who cannot get rid of that fat, who is completely self-conscious, who it's ruining their social life. It makes them feel badly about themselves. These kids get depressed. You can actually, with suction cups and freezing, take away the fat cells. These things that are happening in different labs in different places across the country are only beneficial to the kids and to the adults. The interesting thing is, too, when I talk to families about cool sculpting in the future, the parents say, well, listen, maybe you could do it to me, too. They all want it because it works, it doesn't hurt. People actually sit there on their lap pads or iPads while they're working while it's being done to them. So it's without anesthesia and it's without pain.
How long does it take?
It takes about 45 minutes for a session, and you might need 3 sessions. But after that third session, fat's gone.
So tell us, I mean, there's always a pro and con. So what are the side effects of this procedure?
The complications from cool sculpting have been almost nil. There's a couple of cases where people get hyperesthesias, where they get pain from where the suction cups were placed. And other people sometimes get a breakdown of the fat cells that impairs their kidneys. But it's very rare that these things happen.
So not an expert in this, but just someone who drives around Staten Island and Brooklyn and Manhattan. I see signs up for cool sculpting everywhere. And anytime you see signs with neon signs outside of anybody's office, you sort of look askew. I mean, there's always that part. And when you mentioned this, and I said, you know, you're such a well-known, reputable surgeon, and again, you're doing it now on younger people under an NIH or an FDA guideline. So there's certain rules, requirements, reporting that you're going to have to do. So when someone sees these stores and say cool sculpting,
avoid them.
Well, tell us why.
Because the people who are portraying themselves as being experts in this are not. They have no concept as to nutrition, metabolic needs, and actually how to do the procedures. I think if you're going to have any procedure done, you don't want a cosmetologist doing it. You want somebody who's a surgeon. You want somebody who, either a plastic surgeon or a pediatric surgeon. But going to these places, I think, is really a big mistake.
Is it dangerous to go to these places?
Well, I don't know if it's dangerous. I just don't know if it's effective. You know, you want to go someplace where you're going to get an effect. You're expecting a certain result, and you'll get a certain result if you go to somebody who's expert at it. I don't think you'll get it from people who are just out and about buying these machines.
But if you're an adult looking to do this, you go to a hospital? I mean, or is it you just
No, you have to generally go to a plastic surgeon.
Plastic surgeons do this.
Plastic surgeons do it, and they do it well.
Okay. So tell us any other interesting new procedures that you're doing.
Well, the thing that's not very glamorous, but that you really need to know about is how we take care of pilonidal disease. Pilonidal disease, as you know, is an infection because the skin is underneath the skin at the midpoint above your natal cleft on your backside.
Right.
And people get terrible infections there, and they used to cut out the whole area entirely and leave a wound the size of your fist to heal from inside out. We no longer do that. What we do now is we just take one little needle and we stick hydrogen peroxide under pressure. The H2O2 with the pus creates what's called the catalase reaction. The catalase reaction frees up an oxygen-free radical that kills all the bacteria in that area. That's all you need to do. And I've done over 300 of them that way now. I gave the talk in Paris in 2013, and then at NYU in 2016, and I can't speak more highly of a procedure than to do the pilonidal minimally.
And what age groups are we talking about? I know
Any age group.
So-
I mean, I do only the kids. I see the teenagers, but it works for the adults as well. Those days of cutting out the whole area on your backside, I think should be over.
Are they still doing that?
Yeah, a lot of guys are still doing it. I think it's a mistake. And unfortunately, I wrote this paper on it, and I put pilonidal disease, full colon, cured, which sounded very arrogant.
Right.
But, you know, it is cured by doing it that way.
I think what's so interesting is there's so many people, so many of our patients, so many people viewing who like talk about pilonidal cysts, fistulas, all
Right.
kinds of different words that are used.
Yeah, it's all the same disease
right.
process.
And the idea now that and again, when we spoke in the lounge, you talked about the cool sculpting. I said, wow, that's so interesting. You told me about this, that so many people have this disease, and so many people's grandparents went for these
Sure.
for these major surgeries. They couldn't sit for weeks, and it's much more than just a hemorrhoid procedure. You know, it's much more than that. The idea is, you know, that people can actually get well without major surgery.
I
think
have
it's
these kids going
astonishing.
back to school and back to sports in 2 or 3 days. 2 or 3 days. It used to be 6 months taking care of these wounds. It's a trifecta. You instill the hydrogen peroxide, so under pressure, all the bad stuff goes out. The catalase reaction, which creates the oxygen-free radical, kills the microbes. But thirdly, the 3% hydrogen peroxide causes sclerosis of the membrane, so it's gone. So you get, it's a trifecta, and it works like a dream. And the kids, you know, they're back at it within 3 days.
Have you noticed with COVID any differences in your scope of your pediatric surgical practice? What you're seeing?
So here's the interesting thing. Here on Staten Island, I do about 75 appendectomies a year. 75. In the year of COVID, 2020, I did 17. So I said, this is a perfect opportunity to do a paper. Here's an entire borough that's completely free of anything else. I called the guys at Staten Island University Hospital, the pediatric surgeons, who are friends of mine. And I said, listen, let's write a paper. Let's look at this, because how many appendectomies did you do last year? They said, none. I said, what do you mean none? They said, we did 0. And I said, why is that? He said, anybody who came in during COVID, we treated with IV antibiotics, or they didn't come in at all. So the two questions you have to ask yourself is, did COVID, the virus, somehow change the flora of the GI tract such that you didn't get appendicitis? Or did they just treat them with antibiotics because they didn't want them in the operating room and maybe getting sick from COVID? So those are the two questions that have to be asked. But it changed the entire dynamic, just like it did for myocardial infarctions. You know, things did change.
Stroke also, we weren't seeing patients. I mean, I run a large multiple sclerosis center in New York City and on Staten Island, and the number of new patients diagnosed in that 2-year period was trivial. And we were seeing many patients every month with newly diagnosed with these immunological disorders.
So what happened? See, the jury's still out.
Nobody knows.
Nobody knows. The jury's still out. In the chapter, you know, people are so critical of Fauci and all the other people who are involved. The bottom line is they were doing their best trying to figure out in the fog of war what exactly was going on. And we still don't understand the disease. We will eventually. But I think it's very remiss on people to be critical of those at the front lines, because nobody knew what they were up against. They were just doing their best.
Let's go on to another topic a little bit. So we're going to be we're in the middle of the winter now, but with sun and exposure and cancers in kids. You mentioned melanoma before. There was actually a recent study that came out today with some new treatments in the adult field, you know, with mRNA and one of the immunotherapies for melanoma. Are you seeing more skin cancers in youngsters than you were before?
It's interesting. The thing about melanoma in children is that it's always diagnosed late. It's always in a late stage because people just don't think of the diagnosis. But it is not uncommon, and it is not rare, and it is up. It's certainly the numbers are up across the country.
So tell us about I don't know what the recommendations are in adults actually over the age of 18. The dermatological associations have all recommended yearly skin exams.
We say the same thing in photos. There has to be a photographic documentation of all these kids. We do it all, especially the kids who have BK mole, who have a lot of moles or a lot of freckles.
So those kids with a lot of freckles, that's really what I was getting at. The dermatologists usually follow them.
That's right.
Have you been seeing a lot more of this because of exposure to the sun, or?
Yeah, the numbers are up. But you know, the general pediatric surgeons don't usually get involved in this very much unless it's a true melanoma, because the dermatology people take care of most of these things. But the numbers are up significantly.
You talked about hernias, and that's the bread and butter of what we do. Because again, and maybe just for everyone out there, the word hernia, everybody has a conception of it.
The best way to think about hernias goes like this. It's very. I teach this to the students all the time. A hernia, you should have a membrane that goes. Take your belly button and just think of a membrane going straight across and nothing getting down below. But then what happens is, you have a membrane that forgets to close.
Your microphone's on, so be careful.
It goes down into the scrotum, and that's like a bunny ear going in the opposite direction. You have to put a stitch in that and close it so that nothing can go down. That's the key. That's a kid's hernia. An adult hernia is different. An adult hernia, the way to think about that is, if you have a Venetian blind that's closed, when you're 18 years old, everything's closed and tight. But as you get older, that Venetian blind opens up a little bit and things can protrude through. That's an adult direct hernia. That's the entire difference. One is a bunny ear membrane going down. An adult, it's the wall, which is now weakened because you're not 18 anymore and you're not what you used to be.
And maybe just the word hernia. Something that goes to a place it shouldn't go.
That's right.
You've heard of herniated discs, where discs are out of place, abdominal hernias, where it goes through the belly button, where different parts of you go through.
There's 11 different types of hernias.
Oh, I didn't know there were 11.
Yeah, 11.
Okay.
Yep.
We won't ask you all 11.
Okay, well, you're not going to quiz me. They used to quiz me all the time in medical school.
But the treatments of hernias, again, with laparoscopic surgery, really a much more amenable process, and people do better.
And there's now most people who have hernia operations get a piece of plastic placed in there, so the recurrence rate is almost zero.
Everybody's worried about the word mesh.
Mesh, that's, yeah.
But everybody's worried about it. And
well, of course, because you've got these guys shilling it on the radio all the time. The lawyers trying to sue doctors for putting in mesh. But I mean, my God, mesh has made such a tremendous improvement in people's lives. And of course, every now and then, one of them is going to get infected. One of them is going to get misplaced. These things happen. Nothing's perfect, but the meshes have been magnificent. You don't put meshes in kids. We never put meshes in kids. No? No, because they're growing and they'll outgrow them. And the other thing is kids are hyperimmune. Remember, the body does not like a foreign body for the most part. If you're a kid, the response against a foreign body is quite vigorous.
Brian, I want to say thank you. This is one of the quickest 30 minutes I've ever had.
It's fun.
It's enjoyable. I hope that anyone interested in cool sculpting could look you up, of course.
Yep.
And you're a wonderful pediatric surgeon with a wonderful program. I want to wish everyone a happy holiday. I want to have a little shout out to David Marcus, my producer and director, for all the tireless work he does in order to keep this going on. This is our 8th year. And I want to thank all of our viewers for sticking by us and enjoying our show, and hope we've educated you a little bit. Have a wonderful holiday and Happy New Year to all.
Thanks.
Thank you. Good job.